Okay. Hi, all. So today we're going to talk about musculoskeletal dysfunction. So, when we think of musculoskeletal dysfunction, one of the major issues that comes up is immobilization. So, children who are immobilized are going to have a slew of different problems. You can see here a list of different different reasons for immobilization. And one of those is going to be injury and injury to the musculoskeletal system. It is amazing, though, how kids can just kind of roll with the punches and they will adapt to what they need to. So here you can see a list of the different areas that are affected by immobilization. So you have muscle atrophy, joint contractures, decreased metabolism, a delay of age-appropriate milestones because they're not able to get up and move around, bone demineralization, and in general, activities are going to help, and movement is going to help regulate children's emotions. So when they are immobilized, they're going to have a more challenging time being able to cope with some of the emotions that they're experiencing. They're going to have a sense of isolation. They're going to be bored. They might end up being a little bit sluggish in their responses, and decrease in their communication abilities because they're not out there playing with other kids. They're not interacting with other kids if there's a prolonged immobilization. So the family is going to be affected by this as well, not only because they're going to have to deal with the child in the manner of figuring out how to cope with a child who's no longer able to get up and walk to the breakfast table or get up and walk to the bathroom. And then there's also the logistics of having a sick child. If you have two parents who work and now we have a sick child at home, that's going to have a drastic impact on the family life. Or do they get an in-home caregiver, or is one child or one parent end up staying home? So there's a lot of variations that can occur and a lot of impact that the immobilization is going to have, not only on the child, but on the family itself. Sometimes we're going to initiate some coping skills or try to teach the child some coping skills, some things that the child can do, or get them a punching bag or a pillow that they can hit if the immobilization isn't caused by, or if the upper extremities aren't affected by the immobilization as well. We're going to do art therapy and counseling, and we can do some various things to get the child outside. So put the child in a wheelchair and get them outside, get them some fresh air, which is always going to help everybody's demeanor. So when there's a traumatic injury, it's pretty much going to occur to either the bone, the tendon, the muscle, or the ligament. We can also have injuries to the joint itself. And here you can see the epiphysis, which is the growth plate here, and what can happen with the growth plate itself. So and we have listed here, so a ligament is going to be associated with a sprain, a tendon with a strain, a muscle or soft tissue with a contusion, a femur, so the bone is going to be a fracture, and then joint dislocation. And we will talk more about the growth plate and what can happen to it a little bit later in the lecture. So with a contusion, it's just damage to the soft tissue. So it's essentially a bruise. So you can hear people will say, I have a bruise, or I bruised my muscle, I bruised my bone. So that's going to be your contusion. Dislocation is when the joint comes apart, to the bones dislocate out of the socket of the joint. We're going to have extreme pain with this. And you can see here that's listed that this is more common with children with Down syndrome. Remember, those children with Down syndrome have the hypertrophic musculature, so they're going to have more injuries associated with dislocation because their muscles aren't quite as tight to keep those bones in place where they're supposed to be. A sprain, so we're going to have trauma to the ligament. It can be completely torn, it can be stretched, it can be a small tear, but a sprain has to do with the ligament. And then the strain, again, is the musculotendinous unit. So it has to do with the tendon and the muscle and where they connect. And we're going to, again, have swollen, we're going to have pain. And the difference with this is it generally occurs over time. So this we're going to see in our overuse syndrome. We're going to see this with kids who are playing sports a lot. We're going to see this in our student athletes. So what are we going to do for these guys? So we are going to go with rice and or ice. So rice is going to be the rest, ice, compression, and you notice with wet elastic bandage, because that's going to give us more compression and elevation. We're also going to want to immobilize or support, and that's where the S of ice comes in. So ice is ice, compression, elevation, and support. And you can see casts or splints are also an option, just depending on what the injury is. So when we're looking at fractures, we want to keep in mind that fractures are common. They occur frequently in children, and we're going to treat them a little bit different. That we're going to treat the children a little bit different than we would the adults. The bones in the babies are still very pliable, and we've talked about this previously, but keep in mind that if we see fracture injuries in an infant, that's not associated with, let's say, an automobile accident or a drastic fall or some trauma that would be consistent with fractures. We're going to want to look more into a couple different things. One would be child abuse, because there's the potential for child abuse there for seeing the fractures because they shouldn't be there, or osteogenesis imperfecta, and that's brittle bone disease. We're not going to get too much into that in this lecture. Actually, we're not going to touch on it at all, but there is a lot of information in your book if you're curious about it. I'm not going to test you on it, but just it's there if you're curious about it. There's lots of different stages of it, and it can range from causing deformities to being deadly for the children who are born with the most severe stages or most severe forms of osteogenesis imperfecta. The clavicle is the most common bone that's broken by children, and it's a weak bone, and it's a bone of high impact, so it's very commonly broken. There's not a lot we do for the clavicle break. Sometimes we'll immobilize the arm, depending, and most of the time we just let it heal. We're going to see a lot of, oh, how funny, this says the distal forearm. Well, so you have the clavicle or the distal forearm as the most common break. Your book also says that the clavicle, so we have a couple different options here. So go with both. The clavicle and the distal forearm are the most commonly broken bones of childhood. School-age children are going to have broken bones related to bike injuries and sports injuries most frequently. And as we move on here, we're looking at the types of fractures. So a simple fracture is that the bone it stays within the skin. It doesn't break through the skin. An open or compound fracture, so we're going to see that bone protruding from the skin. A complicated fracture is when we have potential damage to other organs or tissues. And a accumulated fracture is when the bone splinters off and is in some of the surrounding tissue. So in addition to the types of fractures, we also have various types of fracture lines. So you can see with the plastic deformation, that it's bending of the bone. So typically the bone, especially of children, can bend up to 45 degrees before it breaks. So sometimes that bend will not necessarily go back to normal. So we're going to have to do some interventions to reduce that and to make it go straight again. You can see the buckle, which is compression of the porous bone, and it's going to appear raised at the fracture site. And then we have green stick fracture, which this is where the bone gets angulated, so it's bent to the point where it's going to break, but it doesn't break all the way through. And then the complete fracture is where the bone breaks completely. With the periosteal hinge, so this can really just help if this is not broken or torn in the break, because it will help to reduce the fracture back down. It will help the physicians to put the bone back where it should be and help expedite healing. So in addition to how it breaks or how far it's going through the bone and the classification of the break, we have the type. So we could go through the bone at an angle. We could go oblique, or we could go spiral, which is usually a slant with some sort of a twist along with it. So if the leg or the arm was being twisted while it was broken, then we're going to see that spiral type of fracture, in addition to the potential slant of the fracture. So for our growth plates, which is the epiphyseal plate, they're the weakest spot for these kids' bones, and it's specifically in the long bones, and we're going to see damage if there's drastic trauma. We're going to have to keep a close eye on this, because depending on how severe the damage is, it might affect the growth of the child, and it might affect the length of that bone. So it could go anywhere from just a simple splint or cast to fix it to actually needing to do a surgical repair. In the Salter-Harris classification system, we're going to take a look here. So you can see the various classifications of the injury. And you can see how something like this would cause, and this is fractures across the metaphysis, the physis, and the epiphysis. So this is going to cause a pretty significant impact on the growth of that bone. And then here you see how quickly these kids heal. These kids have fabulous blood flow, and they have great osteogenesis, and so their bones heal so quickly, which is really great, because since kids are so prone to accidents and falling and breaking something, it's great that they're able to heal quickly. So when we're looking at a child who has some sort of fracture or bone break, we're going to want to be cognizant of our assessment. And when we're looking at the 6 Ps, we're assessing for compartment syndrome. And I'm sure you've learned about compartment syndrome in med-surg, but compartment syndrome is gonna, if it's not treated quickly, it's gonna end with the death of the tissue and potential amputation of the area. So, or removal of the bone or whatever is being affected. So we definitely want to have our eyes on the 6 Ps to assess for our fractures, because if these are present, then this child is at a significant risk of developing compartment syndrome in that area. So one of the ways that we treat fractures is by a cast, and there's a variety of different types of casts, and recently we've had casts have gotten fun and interesting. So you can see here, this young lady has some some great colors of her casts. And then you see her Cabbage Patch doll here has the casts as well. So especially with preschoolers, we're going to want to show what's going to happen on a doll or mom or somebody else before we proceed with the child, so that we give them the chance to see what's going to happen and to be able to process exactly what's going to happen. These casts are lightweight, they're durable, they're easy to clean, and they're actually relatively water resistant at this point in time. We want the kids to know that the cast is going to be warm when it goes on, but it's not going to burn. We can use some distraction techniques like blowing bubbles or just playing with the child while the bone is being set and while the cast is being placed. For our little ones, we might need to set the family up with caseworkers so that they can obtain a specially designed car seat, because there are car seats that are specific to the type of cast. So you can see that this cast here spans her hips, and her legs are kind of stuck like that. So she's not really going to be able to sit in a car upright with the seat in front of her. So there's going to need some modifications. She's going to need some modifications to be able to go home with this. We're going to want to educate both the child and the family members about placing toys or food items in the cast, and make sure that they are keeping the area clean and assessing the peripheral circulation. So just checking cap refill is a super easy way to make sure that those toes and those fingers are getting the appropriate circulation. When kids when it comes to taking the cast off, some children start to identify with the cast and identify the cast as part of themselves. So this can become an issue when it comes to taking it off, paired with the fact that a saw is used to remove the cast. It can be quite frightening for the children to take the cast off. So we're going to want to educate them at the beginning of when the cast is going on about what they can expect along the way, and that the cast is going to come off. And then when it comes time to take the cast off, make sure they know the saw is not going to cut them, provide them with an alternative, with a distraction and an alternative to supplement the cast. We can also let them know that if they want to take the cast home, they can, so it's not a complete separation from it if that's something that's a concern for them. This is a happy looking kid, huh? Traction. So traction is used when we need to place something specifically. So either a bone in place or ensure that things are staying where they're supposed to be. And if you look here, we have the purposes of traction. So the first one is kind of interesting. One of the purposes of traction is to fatigue the involved muscles. So why would we want to fatigue the muscles? Well, when a bone is initially broken or dislocated or some traumatic injury occurs, the muscles actually contract along with the tendons and ligaments to form a physiological split for that area. So when they're contracted so much, sometimes if you have a bone that's broken and off, so if my muscles have contracted and splinted my bone here, I'm going to have a difficult time realigning that. So we're going to want to fatigue those muscles so they relax, so we're able to realign and keep that bone in alignment. So you can see some of the other purposes here involve positioning the distal and proximal ends, immobilization of the site to prevent deformity, because if I have a fracture that breaks like this, and it could end up healing like that, which is not what we want. We want it to heal in line, and then prevent further injury. And we're also going to reduce muscle spasms, because we've fatigued that muscle, and then the muscle releases and says, okay, I'll do what you want. I'll just hang out here where I'm supposed to be, as opposed to holding so tight in this off-put position. So here you can see we have countertraction, which is the backward force, which is actually the body. So countertraction is going to be, if we're putting traction here, the countertraction is going to be my body. And then the forward traction is going to be what we're pulling on. We're going to want to provide regular assessments for the child, including and the apparatus, to ensure we have skin integrity, we have no infection, that we have pain management. We want to make sure that we're using the appropriate weight. So there's a lot of assessment that occurs with traction. Traction in the standard sense or historical sense isn't used all that frequently anymore. Because of some great technological advances, we're able to do more minimal traction with home devices, as opposed to kind of, if you think about the bed with all the pulleys and the legs up and everything like that, that's not used very often anymore, only in severe cases. So the majority of traction is done with a home device, and then home health is going to be helping out with that to make sure that, again, that skin integrity, the site, especially if there's pins involved, and we'll talk about that in just a second, but if there's pins involved, then we're going to we'll check that wound site as well. Well, I thought I had a slide about the types of traction, but I don't know where it went, so I'll tell you about them. So we have three main types of traction. We have manual traction, which is applied to the body part by the hand. So you have a hand that's placed distally to the fracture, and it's applied by the hand. We can have skin traction, where we have a pulling mechanisms that's attached to the skin with adhesive material or an elastic bandage. And then we can have skeletal traction, which is what I was mentioning with the pin care site. So skeletal traction is applied directly to the skeletal structure by a pin, wire, or tongs, which are inserted into or through the diameter of the bone, which is distal to the fracture. So we're gonna manage our care dependent upon how invasive our traction is. Amputation. So amputation is going to occur in a couple different types of situations. So we could have an infant a newborn who was born without a limb, in which case it's not necessarily amputation, but they might need some surgical intervention to ensure that the stump is shaped appropriately. We might have a traumatic loss, so a car accident or some sort of injury where the limb is lost. We might have to have a surgical amputation due to some sort of disease process that is causing that. When we do the surgery, we're going to want to make sure that the limb that is remaining is adequately nourished with the blood supply and oxygen. We're going to set this individual up with case management to ensure that they get the appropriate prosthetics, and then we're going to want to manage their pain. And with amputation, it can become very challenging because of the phantom pain. That phantom pain is something that's more psychological than physiological. So pain medication doesn't always manage that pain adequately. It can sometimes, but the brain still thinks that arm or leg or whatever it might be is there, and it has a tough time turning off some of those sensors. And so the nerves that are now, the nerve endings and the neurons that are now in the brain, although they don't have input from the limb, it's still firing. So that's why that phantom pain is so challenging to really control. So we're going to educate, and there are some medications that will work pretty well, but it's going to be something that they're going to have to learn to cope with over time. So sports injury, or sports participation and injuries. So a lot of injuries, and we saw that earlier, occur from sports. We have young children who are playing aggressive contact sports. We have sports that require a lot of physical demands. We have kids who are playing sports 5, 6, 7 days a week who are going to end up with an overuse syndrome. So with sports and overuse, it's really going to come down to education of the parents. So most sports require a physical, especially if it's going to be a sport that is at a high risk of injury. The physical is required before participation. So when that physical occurs, that's when the nurse really has the opportunity to discuss these things with not only the child, but the parents as well. And making sure that they understand kids need rest. They can't be practicing, 10 hours a day, the same exact sport. That's going to end up causing problems. And when we get into overuse syndromes, some of the only things that are going to truly be effective is work. I'm reading the word. Nope, not work. Rest. We don't want to overwork them. We want them to rest. So providing adequate rest is what is going to be helpful in those overuse syndromes. If we have a child who is experiencing pain, we can recommend an NSAID, because a lot of the time it's going to have to do with inflammation. So that will help not only with the pain, but with the inflammation as well. And we can do some of the same things we would do with our fractures, like the rice and the ice. So rest, elevation, ice, and providing some sort of splinting or support for the injured limb. Moving on to scoliosis. Scoliosis is a common spinal deformity that occurs in children mostly. And so most of you probably recall being screened for scoliosis in elementary school or maybe middle school. Typically, the screening occurs for girls between the ages of 10 and 12, and for boys between 13 and 14, because remember, the boys are going to develop just a little bit slower physically than the girls are. And with scoliosis, we're looking for the curvature of the spine. And so we have a couple different, the spine can curve laterally, and it can start to twist as well. When that occurs, we're going to have some significant impact on what this child is able to do physically. When we're screening, these are some of the signs that parents might bring their child in for, or might recommend additional screening for. If their child's clothes become ill-fitting, or if they become more tired when doing physical activity. School screening has become controversial just because there's no studies that support an increased proper diagnosis or a better outcome because of school screenings. And really what happens is there's a lot of false positives that are people who are sent for referrals. However, the American Academy of Pediatrics does still recommend school screenings because they figure that we're catching the majority of individuals who have scoliosis, and especially those individuals who might not attend their regular physical appointments. So people who are taking their kids in for physicals every year, the scoliosis will be caught by the physician or the nurse practitioner, but not the entire population doesn't do that. So having screenings in schools is is still recommended by the American Academy of Pediatrics to catch those outliers who aren't able to attend a physical annually. There's the way we're going to diagnose it is if we see, there's a good picture here. So you can see that her spine has a significant curvature, and you can see it bending over here, and you can see the actual curvature here in the spine. You can see that her scapulas are not aligned. The definitive diagnosis is going to be some sort of radiography, so an X-ray or an MRI. We might do an MRI to see if there's any spine involvement. So scoliosis could be called, most scoliosis is idiopathic. It has no definitive start and no real reason, but there can be scoliosis that has to do with some spinal defects. So we want to rule that out as well. And the degree of curvature is going to dictate what we do intervention-wise. So if there's about 10% curvature, we're not going to intervene. That's considered a normal curvature of the spine. Between 10 and 25% is considered mild, and there's not much we do for that either. We would recommend exercises to strengthen the musculature around the spine. When we get into some of the higher curvatures, so the moderate curvature would be between 25 and 45% curvature. We're going to look at bracing the individual and doing exercise. Now, it's interesting because this is the standard of care to do a brace and provide exercises. However, there's no evidence that actually supports that it does anything other than stop the progression. So it can be useful in stopping the progression of the curvature of the spine, but it is not, there's no evidence to support the reversal of the curvature. So we want to be careful with how we communicate with our families when it comes to bracing and exercise. The transcutaneous electrical nerve stimulation has been shown to help to decrease that curvature, but it's not the standard of care, which is always interesting to me. When we're talking about severe curvature, which is going to be our 45% or more of a curvature, we're going to be looking at surgical interventions. So we will be looking at a child who ends up having rods and plates placed in their spine to straighten it out. And again, it can be a curvature not only like this, but the spine can start twisting as well, which is going to have a drastic impact on everything that child does. And these are some of the common rods that are utilized in the surgical in surgery for scoliosis. Here are some of the braces that can be worn. Now you can imagine what psychological impact and social impact wearing a brace like this could have, especially on an adolescent. And so we want to take that into consideration when we are offering these, and when these are being ordered for that child. We're going to want to provide them some additional support to ensure that they are able to transition back into their social life while wearing this brace. So you can see concerns of body image. And this is a treatment that's going to potentially require a long-term treatment. So we're going to need, this child is going to need to be seen into adulthood and potentially have a very invasive, painful surgery. Preoperatively, we're going to want to make sure that these children have a good understanding of what's going to happen. We're going to provide a lot of education regarding some of the medical terminology and how this is going to impact them, what they were able to do before, what they're going to be able to do afterwards. And post-operatively, they're going to be managed in an acute care setting for quite some time. So when they do this, that they either go in through the back and they open up the entire back to place these rods and plates, and they go all the way down the spine, or sometimes they go in through the belly to do it as well. So there is a significant hospitalization in an acute care setting for healing afterwards and care management. When we move these children, we're going to want to log roll them and make sure that we're not irritating the placement. We're going to want to be very gentle and very cautious with the movements that we allow them to do and how we move them. Skin care is going to be a big issue because movement is going to be so drastically impaired for the first little bit. We're going to also want to keep a close eye on the neurological impairment. So doing a neurological assessment is going to be key, because there could be something that's causing some sort of paralysis that would require further surgical interventions that we want to be on the lookout for. And then pain control. This is going to be a huge surgery, and there's going to be significant pain related with it. There's going to be pain that they endure for pretty much the rest of their lives that has to do with having the rods and screws and the potential plates in their back at that time. The family's going to be very involved in this situation. And as with anything, we're looking to support the family and also to provide adequate education. We're going to need to provide a lot of education regarding the home care once they take this child home and what the child's capabilities are now, because the physical capabilities are going to change. And if this is a girl, something to think about for future is that having babies is going to be a little bit more challenging, and getting an epidural is going to be significantly challenging, and some people just can't receive an epidural. So what does that look like from a labor management perspective as well? So this is going to drastically impact their lives in many different aspects. Okay, so Kristen is 10 years of age, and she sustained a fracture in the epiphyseal plate of her right fibula when she fell out of a tree. When discussing this injury with her parents, the nurse should consider that, is it A, healing is usually delayed in this type of fracture? No, it's not delayed. Or it's going to be B, right? Bone growth can be affected by this type of fracture because we have a break in the epiphyseal plate. So it's not an unusual fracture site for young children, and it's also not inconsistent with a fall. So B is going to be our best answer. I hope you enjoyed this lecture on fractures. Super exciting, I know. And as always, please feel free to email, text, or even call me if you have any questions that you want to discuss. Thank you. Have a great day.